Okay, we're good to start then?
We should be good to go.
Okay, welcome everybody. I think we'll go ahead and start. Sorry for the delay. We're a couple of minutes late, but I'd like to welcome you all to today's Bourne Provincial Rounds. This is our third rounds in our series. And I would like to welcome our today's speaker, David Williams. He is a PhD candidate in the Population Health Program at the University of Ottawa. And his doctoral thesis topic is about exploring adverse birth outcomes in Ontario and analysis of spatial clustering of perinatal outcomes. And David is going to talk to us today about some of his findings, the counterintuitive findings. You'll see on the screen that is up on the webinar series today. So I will turn it over to David to present his information, and then we'll have questions at the end. Okay, David, away you go.
Hi, good morning or good afternoon, everyone. Odd thing, these webinars, not really knowing to whom I'm talking or how many. I think with that introduction, we'll move right through the talk. One of the things I find difficult about webinars is it's the pacing. But I also find it's easier to err toward being too slow as opposed to, and so I'm going to err toward moving a little quickly and rely on you all to ask questions if I move through something too quickly. Oh, what I was doing with my dissertation was analyzing adverse birth outcomes. And we know that adverse outcomes are complex and they're changing, they're dynamic. When I say they're changing, meaning the numbers and counts and the rate. We know that premature birth proportions have been consistently increasing, and yet I know within the latest breaking CIHI data suggests maybe they're beginning to level off, but the premature birth rate has been increasing constantly across the past 20 years in Canada and in the States. While SGA birth rates and stillbirths have decreased in Ontario, we know that there are still significant disparities between health regions. Disparities really in premature SGA and stillbirth outcomes. And so we know that they're anything but consistent or predictable. They're also expensive. As I'm sure you all may be aware, the cost of initial hospital costs for a baby are increased in direct proportion to the amount it's premature. And it's roughly about, as I recall, for about 90% of the births that are in normal gestational age, those cost about the same amount in health care as the remaining 10% of babies that are premature or have other adverse health outcomes, adverse birth outcomes. So they're expensive and there are significant disparities. Those were the two driving motivators behind the study. The goal was to better understand the 4 different adverse birth outcomes. And this is an important part of the study. I wanted to concurrently study late, premature, moderate, and very premature, small for gestational age, and stillbirth. It seems as though all the studies I read, I think I'm safe in saying just all of them, really only looked at one outcome. Often that outcome was something very vague, like premature in general or low birth weight. I wanted to look at 4 of the key outcomes, adverse outcomes, concurrently. And the goal was, along the line of the disparities, I wanted to identify hotspots, geographic hotspots. If there are hotspots, I wanted to find out if there are hotspots for each of the 4 outcomes, and then where are they? And are they coming from the same place? Part of asking about whether they can come from the same places is because in population health, which my degree is in, or going to be in, socioeconomic status is such a strong and consistent predictor of adverse birth outcomes that it struck me that if indeed, if socioeconomic status was that strong, then we should see all four of these adverse birth outcomes. We should see hotspots for each of the four in the same places. Putting it somewhat bluntly, we should see, we should see large ghettos of adverse birth outcomes. And correlated with those, we should see low socioeconomic status and other predictors, or low income and low other predictors of other indicators of socioeconomic status. So we wanted to know if these hotspots are in the same places, and then for like outcomes, do the predictors differ in diverse areas? So if we find hotspots in southeastern Ontario, are the predictors of the same, of let's say late premature birth, do we see the same predictors in eastern Ontario as we do, say, in western Ontario? And then do we see, do the predictors differ at different scales? For example, for the full province, for all late premature births in the full province, are the predictor models different than they would be at local area models? I'll explain more of this as we go. Another research goal then for different outcomes, for the four different outcomes, do the predictors differentiate between the outcomes? We were using, well, I'll get into that. So we were both, the goal was to find hotspots, and then once we found them, to model them using regression analysis and look for differences in regression models for both the same outcomes as well as different outcomes. But I'll explain more of that as we go. So the methods, Lord, we basically, our four adverse birth outcomes were late premature birth. And for late premature birth, I worked with births that were equal to or greater than 35 weeks and less than 37 weeks. So, in effect, births that were of 35 or 36 weeks gestational age were labeled late premature. That differs, I know, from some of the standards of 34 to 36 weeks, but because of the need for data, the need to have sufficient data in our sample, also I decided to have it at 35 and 36 weeks. Also, some recent studies strongly suggested that 35 week is a better break point than 34 weeks. Moderate to very premature births then were any births less than 35 weeks. And I should add that really the break between at 34, 30, or 35 weeks is arbitrary. And most of the research I read suggested it was arbitrary, and that really, if we were going to model these, if we're going to model premature birth, we should look at premature as a continuous variable rather than constantly wanting to break it into pieces. Anyway, so the third adverse outcome was small for gestational age, which was the lowest 10% within sexes, and then stillbirths. So those were the four adverse birth outcomes that I was looking at: late premature, moderate to very, and I will come back to that, differentiating between late premature and moderate to very later, and then SGA and stillbirths. So those are our four outcomes. The methods, we used the Born perinatal database. We looked at 5 years worth of data. That was approximately 90% plus of births in Ontario from 2005 to 2009. The Born perinatal database is excellent. It is remarkable because it allows you to look at maternal and birth characteristics for individual births. By maternal, well, we'll get to that, but that's quite unique to be able to do that. We linked about 19,000 births. I'm sorry, what am I saying? We linked about 625,000 births to the 2006 census dissemination areas. I don't know how many of you are acquainted with census dissemination areas, but they're basically Statistics Canada, in its wisdom, has broken Ontario and actually all of Canada up into small geographic areas that have an average population of about 635 people in them. So you can imagine 635 is not a lot of people. That's quite small. And so these census dissemination areas are a fairly small geographic area, relatively. You can imagine, too, though, and it's an important point to remember, that these DAs differ in their size, in their geographic size, by where they're located. A census dissemination area or a DA in downtown Toronto or in a high-end density area of Toronto might be no more than a city block. But up in the northern Ottawa Valley, it might be thousands of square kilometers. So census dissemination areas are excellent because they're a small population area, but the drawback is, and they're fairly consistent in their population sizes, but the drawback is they're very heterogeneous in their geographic size. So I linked birth outcomes from the Born Perinatal Database to, I should have shut that cell phone off. So I linked birth data from the Born Perinatal Database to census dissemination areas, and that in turn allowed us to link to census variables from the 2006 census. And we'll get back to that. We'll talk more about those variables. So after all the grooming and after all the fuss and muss with the data, we ended up with about 622,000 births, information for 622,000 births, linked to about 15,808 Ontario DAs. That's a lot of births, and it covers a great deal of the province of Ontario. A lot of data. We used the first step then to answer the question of, are there hotspots? And by the way, I'll stop and say a hotspot is a cluster of DAs. Because to do spatial analysis, well, there's a number of ways to do it, but I had to link these births to DAs. Because of confidentiality, really, we can only look at aggregate births. We looked at individual births, but individual births within a geographic area. We couldn't use what's called point data, where we look at individual birth information. So we used local Moran's eye cluster analysis to identify hotspots, and hotspots are clusters of DAs, 2 or more DAs with a level of an adverse outcome significantly higher than the surrounding DAs. So it's an island in the middle of not always an island, but generally an island in the middle, an island of significantly higher adverse outcome level surrounded by DAs with lower levels. So to identify hotspots, we use local Moran's eye. And indeed, we found, yes, there are hotspots, which isn't too big of a surprise. It isn't too big of a surprise. For late premature births, we found 132 hotspots. For moderate to very premature births, we found 152. For gestational age, we found 252. And for stillbirths, we found 27. The hotspots were made up of, you see there in the parentheses, the total number of hot DAs. That's the number of DAs that were included in those hotspots. Number of adverse birth or percent adverse birth outcomes for each of these different hotspots. Late premature had approximately 6.2% within the hotspots. 6.2% late premature. For the province average, it's 4.9. For moderately premature, it was 5.85%. For the province, that one came in at 3.69. SGA, as you see, is 13.16%. For the province, 9.14%. Stillbirths, almost 1%. And for the province, about 6%. So you can see the hotspots did have significantly higher levels on average than the provincial average rates for each of those adverse birth outcomes. Yeah, I guess that's about what. Notice too, though, by the way, and I was very concerned about the fact that I broke late and moderate, very premature at a place different than is thought of as standard. But notice that by doing that, as I mentioned, I was concerned about making sure there was sufficient data. The numbers of hotspots are roughly equivalent, which means the break that I gave it was not bad at all. Okay, so where are the hotspots? Well, one of the things I discovered about GIS analysis, Geographic Information Systems analysis, is that maps are very misleading. And when you start showing clusters or hotspots on a map, especially when those clusters are DAs, it can be extraordinarily misleading. I did not show the hotspots as made up of the DAs because it made you think that the Upper Ottawa Valley was this huge, monstrous hotspot, where in reality, in terms of numbers of births, it was no bigger of a hotspot than any of the southern Ontario hotspots. It's just geographically bigger, but it doesn't represent any more births. So you can see here I think the most interesting thing about these maps is to be able to compare them. So I'm going to go through them relatively quickly. Here's the late premature hotspots. Notice a fair number of hotspots over around Ottawa, Toronto, and some up around southern Georgian Bay. When you switch to the moderate to very premature, many more around Toronto and the south of Lake of Toronto, fewer and fewer over around Ottawa, but you're starting to get them going up the Ottawa Valley to the north. So the characteristics of where they're located do change. SGA, what a radical difference. Toronto is SGA central. Strong clustering around Toronto. And then notice in the Greater Toronto Area map, fairly strong clusters here in the east and in the northwest. And I come back and do more detailed analysis of those areas later. And then stillbirths are pretty evenly spread around the province. There's only 27 of them, and relatively few around Toronto, but quite evenly spread. Little dots are each a hotspot. So let me just walk you through those real quickly again. Whoops. And you can see, if you just watch the map itself, you can see how the character of the locations differ between the different adverse outcomes. That's about as useful as maps get. The next question is, so that's where are they? And then the next question is, are they in the same places? Are they in different places? One of the things we discovered is that hotspots for the different outcomes are largely geographically exclusive of each other. I was very surprised by this because I was thinking that, some of the ghettos, some of the low-income ghettos around Toronto and some of the Rust Belt areas were going to be the home of all the hotspots. But we discovered that's not true. Hotspots across the 4 different adverse outcomes do not share the same places. We did about 4 different statistical tests, but a couple of them that are relatively straightforward. If these hotspots, hotspots were from the same place, then we would expect them to share the same DAs, right? Let's say you've got a bunch of low-income DAs. We expected there to be significant or hotspots for all of the different adverse outcomes from these same very low-income DAs. But what we found, for example, is that late premature and moderate to very premature, there's only share 70 DAs. And that's only 4.5% of all the DAs or hot DAs that make up those hotspots. So they only share a little less than 5% of their DAs. Late premature and SGA only share 2.6. Late premature and stillbirth only share 0.6, less than 1%. Moderate to very premature and SGA share 3.6. Moderate to very premature and stillbirth share 3.1. And I guess that makes sense because moderate to very premature are fairly highly predictive of a stillbirth. But still, 3.1 is not much in the way of sharing these DAs, and SGA and stillbirth share about 1.5%. There's a test we ran called the Kappa coefficient, which measures the degree of agreement. there's a certain amount of agreement you would expect by random chance. And what it found, notice all these numbers are negatives. And especially between moderate, late premature, and moderate to very premature, with that negative 0.1, suggests far less agreement than you would expect by chance alone. Or put a different way, a lot more disagreement than you would expect. So there's all sorts of explanations. I've talked this one over with a number of biostats people. Regression to the mean was proposed as a possible explanatory as a possible way of explaining it. In other words, if something is significantly high in late premature, you wouldn't expect it to be significantly high in moderate to very premature. And yet, the two other statistics tests we did, which were Pearson's R and Spearman's R and another GIS tool, a binomial Moran's I, also said these things didn't share the same DAs, and it isn't just because of regression to the mean. Anyway, just to say we were surprised, I guess I'll wrap that up by saying we were very surprised, I was very surprised to find these hotspots are mutually exclusive of each other. All right. Next slide. All right, the next research question. So we found these hotspots for 4 different adverse outcomes. So the question is, for like adverse outcomes, are the explanatory risk factors the same or are they different? I'll pick on late premature, and I mentioned this earlier. The question is, are the predictor variables or the explanatory risk factors, are they the same in eastern Toronto compared to western Toronto? Are they the same in the north compared to the south? That was the big question. Do the same adverse outcomes have different explanatory models? And then second, for the different outcomes, for the 4 different outcomes, do our models, are we able to differentiate between those 4 outcomes given our risk factors, given the predictors that we have, which we'll talk about now, I think. Methods. Oh, nope, not yet. Now, one of the things we discovered was hotspots are too small of birth clusters because of confidentiality concerns and because of hierarchical regression analysis rules. We couldn't analyze individual hotspots. First, mainly confidentiality. You can fudge statistics, but confidentiality, I'd agreed with Bourne to keep the groups or the numbers large enough to assure confidentiality, and most of those numbers couldn't be met by individual hotspots. So we had to group hotspots, and you notice, going back to those maps in your mind, those maps I showed you earlier, there were groupings of hotspots very close together, and we grouped those, and I'll talk more about that in a minute. But we were not able to do that with stillbirths. I mentioned the stillbirths were pretty much spread out around the province. Also, the rate of stillbirths is so low in hotspots that for confidentiality reasons, we could not do hotspot analysis using stillbirths. So from here on, we're just going, except for at the provincial level, we're just going to talk about the 3, the premature and the SGA outcomes. All right, so I talked about grouping these, and for late premature then, our groups were Northern Toronto, which had, this group was made up of 12 hotspots, 64 hot DAs, St. Catharines, which was made up of 4 hotspots, 25 total DAs, and southwest of Ottawa was 4 hotspots and 14 DAs. Moderate to very premature, Hamilton, Cambridge, Southern Georgian Bay, and North Ottawa Valley. I was only going with 3, and yet Southern Georgian Bay offered us the opportunity to look at a rural, or certainly more rural, spread out set of hotspots, and I really wanted to look at that. So I included Southern Georgian Bay to see if the urban population density influenced the birth outcomes that much, influenced the predictors. And then SGA, as I mentioned back when we were looking at the maps, East Toronto was SGA Central, so I have two hotspot groups there. One is in eastern Toronto and one's in northwestern Toronto. I pointed those out when we were looking at the maps. And in London, down in London. One thing I want to point out, notice eastern Toronto, that hotspot grouping is made up of 55 hotspots and 201 DAs. This is a very big group of hotspots and a lot of births in it. The reason I point that out, that'll come up later when we're looking at the models. Northwest Toronto, too, is quite large. In fact, I guess if you want to compare them, these two, Eastern Toronto and Northwest Toronto, are large, or are as large as almost anything the other groups have to offer. So lots of data in SGA to analyze. And I'll bring that up again when we're looking at the models. But those are our hotspot groups that we analyzed using hierarchical regression analysis. I thought they were pretty well spread out. One of my goals was to look at diverse hotspots. And I think we did a pretty good job of being able to show hotspots from a fairly widespread areas in Ontario. All right, hierarchical regression modeling. Goodness, if you ever want to change the meaning of life as you now know it, become intensely involved in hierarchical regression modeling. Basically, hierarchical means multi-level. Forgive me, I don't know how many of you are acquainted with this. It basically allows you to consider risk factors at the individual level and at a DA level, where in the past it couldn't. Most statistical tools wouldn't do both of those at the same time. At the individual level, we were able to look at older maternal age, that is greater than 35 years, teen maternal age, as in mothers under 20 years of age, did the mother smoke at any time during pregnancy, and did the mother have a pre-existing health problem at time of birth. So those were our individual level risk factors that we were able to get from the BORN database. I mentioned earlier how remarkable BORN is, and they are, for having those variables linked to an individual birth outcomes. Our ecologic level or census DA level risk factors were median household income. So we were able to get estimates from the 2006 census per DA, right? So looking at 650 residents within a DA, we were able to estimate their median household income, urban versus rural, and then education level. So we got percentage of the women greater than 20 years of age, the percentage with less than a high school degree, and the percentage with greater than a bachelor's degree. So these were women that had gotten out of high school. They were already, actually, I think it was 22. I believe it was greater than 22 years of age. Percent with less than a high school degree, percent with greater than a bachelor's degree. Higher education was picked on because it was, in a number of studies, it suggested that women with higher education is a proxy for older age mothers. So we included that. And then lower education, of course, is just that, a proxy for low education. And then we also included at the DA level percent Asian immigrant population, specifically Southern Asia and Eastern Asia, which is a very major risk factor for SGA births. So hierarchical regression analysis allowed us to look at both individual level and ecologic level risk factors in the same model. For late premature, the risk factors for the full province, at the full province level, late premature births, we saw no diploma interacting with older age. So older women living in a DA with a high rate of low education, that's a tongue twister. Older age women living in a low education, DA have a higher risk of a late premature birth. High percentage Asian urban DAs are protective. In other words, people living, the higher the percent Asian in an urban DA, the lower the risk of late premature birth. Interestingly enough, teenagers with health problems had a lower risk of a late premature birth than non-teenagers. So teenagers deal better with health problems when it comes to having babies. But teenagers living in urban areas are at greater risk of having late premature births. So it's interesting. Clearly, teenage, and we'll see this again and again, teenage has an inconsistent role. Sometimes it's protective, sometimes it's at risk. It depends on the interaction effect that we'll see several times as we go. All right, hotspot groups. So here on the right are the 3 different hotspot groups of North Toronto, St. Catharines, and southeast of Ottawa. Notice that the models are much simpler. In Northern Toronto, for example, the only risk factor was older age interacting with no diploma. St. Catharines, no diploma interacting with a health problem, and southeast of Ottawa, older age interacting with higher education. In this, couple things I'll point out relatively quickly. One is, interestingly enough, no diploma interacting with older age is consistently a strong predictor whether you're looking at a full province model or at hotspot groups across the province. No diploma, low education appears very strong. And in this case, with higher education, the background analysis showed that higher education here was actually just a proxy for education. And we saw that quite a bit. There were some exceptions, but in general, I found percent higher education didn't particularly act as a proxy for older women. It wasn't a risk factor. It just turned out to be a measure of education. And in some areas where you had higher education, more women getting postgraduate degrees, higher education kicked in as an education measure. But it was usually protective, as showing a more highly educated population. So basically, for late premature births across the province, when you're comparing, full province compared to the hotspot groups, older age and no diploma are consistent and repetitive. Notice, though, at the full province, now full province means for all late prematures everywhere in the province, we did a model. And what we found, notice, is that percent Asian and urban, health problems in teenagers, and urban and teenagers, those were significant at the provincial level, but they don't even show up in the hotspots, which suggests that our hotspot groups, whatever the etiology is that can explain a significantly high level of late premature births, it's different. It's different than the full province models. Okay, moving right along. For moderate to very premature risk factors, you know what I'm going to do? I'm going to jump to the next slide, because I think it's even better just to show these two side by side. For the full province, here you notice I didn't circle anything and show comparisons, because really the two models, the models at the full province level and at the hotspot groups, are quite different. At the full province, Asian interacting with teenage is a risk factor. Percent no dip in older age. Notice there is a commonality with late premature. Percent no dip in older age. Women as a risk factor, and that's an interesting one because you'll find that's consistent across all 4 adverse birth outcomes: education and older age, but also low education interacting with older age. Median income interacting with smoking. Interestingly enough, that was protective. As median income increases, the risk that smoking introduces decreases, which makes some sense if you think about it. Urban, people who smoke in an urban setting, high risk. People with a health problem that smoke, high risk. Imagine that. Teenagers who smoked, again, the teenage body is better equipped to handle these risk factors like smoking. It was protective. And again, teenagers with a morbidity was protective. Really what that says, and we'll see that again later, is that teenagers had a lower risk of moderate to very premature births when it was interacting with some of these high risk factors like morbidities, as in health problems, smoking, and oddly enough, percent Asian in the neighborhood. In the hotspots, notice a couple of commonalities. Median income actually shows up as a protective. The higher the income levels in the North Ottawa Valley, the lower the level of risk of moderate to very premature birth. Higher education and smoked, again, that one's protective. That one, as I recall, did show up over here. Thought it did. Median income in higher education is protective. Smoked and Asian is protective. And a health problem. This one's very odd. Why the higher the percentage no diploma interacting with women with a health problem is protective? I can only assume that if the woman has a health problem, she's seen her doctor and is less likely to have a moderate to very premature birth. And then median income and higher education here again in South Georgian Bay. But I have to point something out that's fundamentally important. Notice median income interacting with higher education in Cambridge is protective. Median income interacting with higher education in South Georgian Bay is a risk factor. What this is saying is the same outcome, the same adverse outcome, moderate to very premature, has different risk factors. Well, though they aren't different risk factors, they're the same risk factors, median income interacting with higher education, but that predictor has a different effect in two different local areas, South Georgian Bay compared to Cambridge. What that suggests is for a GP or someone else working with mothers is that you really can't trust the bigger full provincial model. You've got to look at your own local area because even local areas differ drastically in the different what predicts a moderate to very premature birth. SGA factors. SGA had an immensely complex, far more complex model than the others. 12 different interaction factors compared to 7 for moderate to very premature, and as I recall, it was 4 or 5 to late premature. This suggests SGA is a very complex cluster of different outcomes, really, indicated by small for gestational age. But, really just to summarize some of these, notice median income is very strong in this model. So median income is highly predictive. Generally, the lower the income, the greater the risk of SGA. Notice, too, smoked is very strong in this model. In fact, I think it's the strongest one. 1, 2, 3, 4, 5, 6. 6 of the interactions are with smoked. I know that's basically in agreement with most of the research that's gone on before this, but what it does show to me is that, one, smoked is not individually significant. Smoked is significant in interactions with morbidities, interactions with Asian, interactions with no diploma, with urban, with older age. And as it interacts, it has different effects, but still, median income and smoked are all very powerful in SGA. And I think in all cases, we can pretty much generalize and say the lower median income, the higher the risk of SGA, the more the existence of smoking, the higher the risk of SGA. Notice a couple of other things. No diploma, which we've seen in the other two adverse outcomes, is also pretty strong. And then again, teenagers, it's protective. Teenagers with a health problem have a lower risk of an SGA birth than older women with a health problem. Comparing these, the only thing I really want to point out here is, well, there's two things. Notice how fundamentally different the models are. You go from such a big, complex model at the provincial level. When you look at the hotspot clusters, the models are very simple. And they're not simple because of small sample sizes. They're simple because these local groups have a much simpler etiology. We're looking at a more homogeneous population, which suggests that for some reason SGA births are local geographic areas are more definitive of the predictors of SGA births. These are very simple models compared to the full province. Notice no interactions. The full provincial model is nothing but interactions in the model. At the local level, there are no interactions. And then at the local level, teenage shows up and age clearly is fairly predictive, and smoked is predictive. Although it's interesting that smoked only shows up in London. Teenage, I want to point something out. In eastern Toronto, teenagers are protective. Teenagers have fewer small for gestational births than older women. In northwest Toronto, which is no more than, 20 or 30 kilometers away, teenage is a risk factor. Teenagers have a higher rate of SGA births. So these two hotspots, East Toronto and Northwest Toronto, which you saw on the map, have different models. They have, the models are too close to, teenage is common to both models, but teenage is protective, and in the other, teenage is a risk factor. So again, this underscores the importance, or just how different these local groups, these local area models can be, and that if you're a general practitioner or someone else working with women that have had babies or are going to have babies, if you're an OB-GYN, you need to work with local models, because either your broad provincial level models aren't going to tell you what's going on locally, and then even local models, you've got to look at your own specific area. That title's wrong, sorry. Says SGA risk factors. This is stillbirths. Again, for the full province, interestingly enough, I think this one's because of the small sample size. For stillbirths, the big predictors are older age, median income, and no dip. See, again, we see older age and no diploma consistently strong across all four outcomes. Older age, no diploma. Median income is not so consistent. It definitely wasn't strong in either of the premature birth models, late or moderate to very premature. It was median income was present in SGA, and SGA, and it's present here in stillbirth. But median income is not that predictive of moderate to late premature. Certainly no diploma in older age. Well, I'm getting ahead of myself. Here's comparisons. Here I am. I've been talking over myself. I want to wrap up here in about 1 more minute. We did start a little late, though, didn't we? Just to show you some of the comparisons between the full province models for the 4 different adverse outcomes. Late premature compared to moderately very premature. Interestingly enough, older age with no diploma, that is shared. Teenage with health problems is shared across the two different models. But there's so much that isn't shared between moderate and very premature and late premature. Smoking, for example, is strong in moderate to very premature. It doesn't even show up. It shows up in late premature. But smoked interacting with these others. Boy, I almost lost smoked, didn't I? Smoked is strong without a doubt. But interestingly enough, within moderate to very premature, it's an interaction effect, where in late premature, it's a standalone independent predictor. But my point is that really moderate to very premature represents to me quite a different set of births than late premature, and the predictor models suggest hold that to be true. Moderate to very premature actually shares more predictors with small for gestational age than it does with late premature. Interestingly enough, teenage and health problems are I pointed this out before. Teenage with a health problem It will be. Just looking at a question. The teenage health problem is protective all the way across. Teenagers with health problems are less likely to have late premature birth, are less likely to have any adverse birth outcome than older women with health problems. So there are commonalities that are shared across the models. Comparisons across the provincial models, we've pretty well talked that through. I think I'll skip ahead. Comparisons across local models, very different. Within late premature, we see the local models quite common. Older age and no diploma and health problems, older age and higher ed. Education has a consistently strong role in late premature across the local models. And with moderate to very premature, we see education, all the way down the line. We see smoked once, twice. So fairly strong predictive comparisons across the different local areas. Certainly more the same than I expected, given how different, for example, South Georgian Bay is from Cambridge, or how different Hamilton is from North Ottawa Valley. And then within SGA, I don't know. That one, I think that there's things going on in these local models that are making them quite different. Let's see, contradictory findings. We're just wrapping up now. Hotspots for the different adverse outcomes are largely spatially exclusive. So what that suggests is that the 4 different adverse outcomes are coming from different population groups. Teenage is protective. In general, if a teenage woman walks into your office and she's pregnant, I know that's an issue right off the bat, but especially for older teenage women, I have to preface by saying older teenage women, 18, 19 years old, they're actually at less risk if they've got either a pre-existing health issue or have one of the other high-risk factors. A teenager is better off, more likely to have a healthy baby than an older woman when you're introducing some kind of a risk factor. Median household income, we didn't find a major consistent presence that most studies do, and that ecologic levels of education are more influential. If you know a woman's coming from a low education area, and especially if she's older, if she smokes, if she has health problems, if she's coming from a low education area, you've got a real risk on your hands, a high risk, where income doesn't seem to be that consistent of a predictor. Conclusions, you got to get small spatial analysis. Don't think you know what's going on with your adverse. Don't think you know what your predictors are around adverse birth outcomes from provincial level models. You've got to look at models for these adverse outcomes for your local area, because otherwise the models aren't telling you what's going on. Another conclusion, that the ecologic and individual level risk factors and the interaction between them are both important, especially ecologic. And then lastly, preterm and SGA each need to be analyzed as a multifaceted phenomenon. It's amazing to me still how many people, I just broke preterm into 2 groups, and it showed how different they are. It would be very interesting to break preterm and SGA down into continuous variables and analyze them again. I want to thank BORN and Statistics Canada. BORN that's an excellent database. Population Health Improvement Network gave me a small research grant, and Ian McDowell, my dissertation supervisor, is a great man. And with that, I will quit. It's 12:50. I think I got all that done in 45 minutes. Sorry if I ran a little bit over.
Thank you so much, David. We appreciate that. Excellent timing. Yep, we have a nice few minutes for questions, and I'll just give a little instruction. I think you probably see the green bar at the bottom, left-hand bottom of your screen. To any participants, you can type a question into the chat box there, or alternatively, you can press 01 on your telephone keypad to place your question in a queue, or 02 to take the question out of a queue, and Val will moderate or monitor the telephone questions for us. So I will try to scope through the questions here. One says, David, since local boards of health are mandated to promote healthy birth outcomes, it seems that they should be aware of this work. Are there any plans to share this with public health and medical officers of health? Can you comment on that, David?
Yeah, should I answer these in writing or verbally?
Oh, no, just go ahead and speak.
Oh, okay. Yeah, actually, obviously my next step is to publish the material. The dissertation is a monograph, and what I need to do is pull material from the dissertation and publish it in a series of papers. I'd actually like to look at alternatives to that as well, and possibly talk to the Ontario Public Health Agency and see if there's ways of communicating this information without the 2-year cycle necessary for a peer-reviewed article.
Okay, thanks. We have another question you actually made reference to already. Will this webinar be available at a later time on the Born website? And the answer is yes. They'll be stored, as all our webinars are, on the Born website, so you can look for that later, or colleagues who haven't been able to join us today can search for the webinar there.
By the way, if anyone listening knows about that idea of how it might know of a way to get this information into an Ontario Public Health Agency information source, let me know. I'm not that knowledgeable about the agency.
Another question here, did the data take ethnic groups besides Asian into account? For example, Aboriginals. Does small for gestational age data for Asians acknowledge the new mean size data? Can you comment on that, David?
Yeah, I'll answer it in sequence. No, I did not include Aboriginal in this study for 2 reasons. One, because of ethics approval. I admit, if you start talking about wanting to evaluate Aboriginal as a risk factor, ethics approvals all of a sudden become extraordinarily complicated. 2, a previous study suggested that Aboriginal, if you adjust for income, education, and location, Aboriginal doesn't have that great of an effect. I admit and then 3, because so much of the census information around high Aboriginal population areas is suppressed, I didn't feel the census information would be good enough. I'm not acquainted. To what are you referring around the new mean size data? The SGA tables we were using were the most recent, released by the Public Health Agency of Ontario. Is there something newer than that?
I'm not sure. Sandra, who wrote the question, can you give us any additional background to your question?
We can go on to the next question, and they can come back later if they wish.
Yeah. I'll just check with Val for a minute to see if there are any calls in the phone queue.
Right.
Any calls, Val? Does not sound like it. Okay. Oh, here's another comment from Sandra. Can't remember source, but apparently new data for weight ranges for Asian weight graphs is her comment. So whether or not you have...
I appreciate the thought. I know there are a couple of articles published fairly recently that, strongly propose there should be a set of SGA weight graphs adjusted for Asian heritage, but they weren't available in terms of for the full province. They weren't available for this study. But I think it'd be great if they were, especially given that it seems pretty clear that Asians do have lower weight babies that are perfectly healthy.
Okay, thanks. Abdul suggests that he thinks it was Joel Ray's paper and JOGC, perhaps, that is being referred to, the weight graphs in that paper. Oh, Sandra says yes. So.
All right. Thank you.
Any other questions from anyone? Go ahead and type it in the chat box. We have another minute or two if there's anything else you would like information about. We'll just give it a minute and see. Val, any calls in the telephone queue?
Well, there's one that's come in about smoking variable. Was the smoking variable improved? Bourne is pretty careful with the incomplete rate. Of course, and they released it to me. I cannot, right off the top of my head, remember proportions of smoked that were included, but I do know that my regression analysis tool, if there was missing data, it automatically adjusted for that. So, Bourne, I was working with their 2005 to 2009. I don't know, and they released the smoking data, so it had passed a threshold for completeness. But then I think they may have released it to me because I was working at the individual level, and they were there, and as I said, my regression tool corrected for missing data. Did data divide teens into greater than 16 and under 16? No, it did not. The Bourne data just had less than, I believe I'm correct in saying it had under 20. I believe I'm correct in saying that.
And another comment there, what were the health issues in teens?
I don't know. Because of confidentiality, all I was able to get was that the mother had a health issue or did not have a health issue.
Okay.
That was all the information I was able to get. That would be a good future analysis question, focusing more specifically on that.
Okay. Val is commenting that for some reason she's unable to mute and unmute the phone calls. If anybody is trying to call in through the phone queue, please don't use that route and just type your question into the chat box. And we just have one more minute. Looks like there's a question from Brittany. Just a comment. It could be interesting to take into consideration immigration status could align with Med Inc.
In the end, Brittany, one of the things in working with the percent Asian, I expected percent Asian to be a risk factor for SGA, right? Asians have small babies. But in reality, consistently, percent Asian appeared to line up more with the healthy immigrant effect. Percent Asian was protective against, as I recall, all of these. There was only one local area where percent Asian actually showed itself as a risk factor. It was protective, and in my discussion, I assume it was protective because of the healthy immigrant effect.
Thanks so much, David. I think we're going to have to sign off now. It is 1 o'clock, and that's our allotted time. I want to thank you so much for taking the time and presenting your very interesting work. And also thanks to everyone online for coming and sharing your lunch hour with us. I'm Sandy Dunn. I did neglect to introduce myself at the beginning of the call. I apologize for that. I'm Bourne, Ontario's Knowledge Translation Specialist, and we'll say sign off for today. We look forward to seeing you in the new year. Our next Bourne Provincial Rounds will be January 24th, and you will receive announcements about that in the new year. So happy holidays to everyone, and we will talk to you next year. Thanks so much. Bye now.